Well, hello, everyone. It's an absolute pleasure to have you with us today. Parliament is now in session, and so is today's meeting of the All-Party Group on coronavirus. Today, the All-Party Group is going to hear evidence on long COVID and employment. And in particular, we'll be looking at the classification of COVID as an occupational disease, of long COVID as a disability. The first session that we have, we will be speaking to experts in this field, trying to understand the landscape in which we can put forward the case to government for why they should be taking this more seriously than they are. And around 12:15, I'll be moving to a panel of those who are living with long COVID. To remind people of some of the numbers, the latest data shows that just under 2.3 million people in this country are now living with long COVID in some form, with increasing numbers of people living with it for more than 12 months, in some cases more than 2 years. So to make sense of this, we have an esteemed panel in part one. I'd like to welcome Dr. David Strain, first of all, who's the chair of the Board of Science at the BMA. David, if you don't mind, can I call you David?
Please do call me, yes.
Thank you very much. Has led the academic response to the risk assessment of healthcare workers with regards to COVID-19 from within the BMA. He's participated in the NHS Long COVID Task Force and is the clinical lead for COVID services at Royal Devon and Exeter NHS Foundation Trust. So welcome, David. Thank you so much for joining us. We also have with us Dr. Leslie Rushton, who is the chair of the Industrial Injuries Advisory Council, which we'll refer to as IAC, because it's a little bit of a mouthful. Dr. Leslie Rushton is the chair, as I said, and it's an independent scientific advisory body that examines industrial injuries benefit. She has over 30 years of experience in the fields of occupational, environmental, and public health. Leslie, may I call you Leslie? And thank you so much for joining us.
Please do. Thank you. Thank you, Leila.
And last but certainly not least, we have Shelley Asquith. Shelley is the Safety and Wellbeing Officer at the TUC, and she has led the TUC's work on COVID as an industrial disease and has expertise in workplace safety and workers' rights. Shelley, thank you so much for you to join us today. It's really important to hear your perspective. Really, really appreciate it. So let's get down to it. Now, since we last took evidence on long COVID, and I think this is possibly the fourth session, possibly third, it's now a long-running theme of the All-Party Group, there's been a growing awareness of the condition and its effects, which we very much welcome. And so my first question to all of you, and then I'll ask each of you different supplementaries, do you think that the understanding of the nature of long COVID in the workplace has improved over time? Perhaps I could start with you, David.
Thank you, Leila. So we are getting a much greater understanding of long COVID in general. There are several theories that are all coming together, and the evidence is supporting for the underlying causes. And actually, there's a lot of similarities that are coming out between long COVID and myalgic encephalomyelitis, ME. So we are starting to see that there is a subgroup of people who've got long COVID that are behaving as if they had ME. That is, that the disease is almost stable. It's coming in relapsing, remitting waves, and it just isn't improving for some people. One of the advantages we've had with long COVID is because of the greater awareness, it's not being faced by the same stigma that we saw with ME when that was first described in the 80s. And also there's been a tremendous amount of research money that's been pumped into finding underlying causes and looking towards treatments for long COVID. So we are getting a greater understanding of the disease itself. When it comes to within the workplace, though, we are seeing that we are getting differential understanding of the requirements of a person who is experiencing long COVID. We are seeing that many individuals are coming back to work and they are working as if they're back to normal. And then as a result, that causes a trough. And we do see this cyclical pattern where people come in, they think they're doing really well, And just by doing a full day's work, which is, what everybody really wants to be doing, that is enough to trigger the fatigue that can last for a few days afterwards. And so depending on the support of the environment that people are working in, many are getting phase returns so that they're able to manage their work according to their symptoms, but some are not necessarily having the support. There's not necessarily the greater understanding from the management, from the hierarchy within these workplaces, that can appreciate that it is better to have someone coming in for 2 hours, then giving them a 3 or 4 hour break, and then another 2 hours work, because at least they are contributing, they get their sense of self from their employment, and they can contribute to their workplace. And for many people, they would rather be doing that than sat at home, not working, but being able to do that in a supported manner, that we can give them a route to do a little bit of work, give them that sense of self, give them the completion, help them to contribute, but knowing that by doing that on a regular basis, you will preserve their overall health. And that's just starting to be appreciated. And it does depend very much on the support structure which you're based in.
Thank you very much. And just as a quick addendum to that, I mean, our understanding is that the special leave, which had been granted in many trusts, has now broadly ended. Should this be replaced with some kind of scheme for those who have long COVID? What's the BMA's view?
It absolutely. We need to be supporting particularly those people. I mean, you mentioned the startling figure of around 500,000 people now who've had this for 2 years. If we look at healthcare workers, very much in the front line when there wasn't the same understanding of the disease. So the FFP3 masks were not widely available, the full protections weren't available. As a result, they contracted COVID in the workplace because they were caring for other people. I mean, I myself caught COVID when I was looking after a patient who was having a COVID seizure. And at the time, we had the recommended personal protective equipment, but now we understand that that is woefully inadequate. For these people who've got long COVID 2 years down the line and are now suddenly facing redundancies, they're facing special measures, they are facing losing their livelihoods because they have reverted to their standard sick pay because they were caring for patients with this unknown disease. There does need to be some sort of protection to give them the time and the effort and the support that they need to come back to hospital. Latest figures suggest that it's about 5% of the healthcare workforce in the UK has got long COVID that is in some way causing a debilitation. So that amounts to what, about 95,000 people, give or take, are suffering. And if they're in a position that they are forced to make a choice between coming back to work, knowing that they're not at their best and therefore are providing potentially inadequate, even unsafe care, or staying off sick, losing their job and potentially not feeding their family, that puts them in an impossible position. And it's not safe, it's not fair on the individuals, and it's not safe for the people that we care for either.
Thank you very much. Shelley, can I have the perspective of the TUC, first of all, on recognition in workplaces that long COVID exists and how people are managing it?
Yeah, well, just in terms of what's changed, I think the biggest change that we've seen really is the sheer number of people who are experiencing these symptoms and the number of people who would now meet the definition of disabled under the Equality Act. And just according to the latest ONS data, 2 million people now living with self-reported long COVID, 3% of the population. David talked about how long people are experiencing this for, but just in terms of symptoms, 1 in 6 say their ability to undertake their day-to-day activities, including work activities, has been limited a lot. And comparing that to the data from a year ago, the numbers have doubled, with there's fewer than 200,000 people a year ago saying that their day-to-day activities have been limited a lot. So this growth of people experiencing a new impairment, of becoming disabled as a result, is unprecedented. And I think due to the type and the longevity of the symptoms, many are likely to meet that definition of disabled, giving them protections from disability discrimination and access to reasonable adjustments and disability leave. But that isn't being translated into the way they're being treated in the workplace, and it's not being recognised by government. I think it's also worth noting that there's a higher prevalence amongst certain groups of workers as well. So those working in education, in health and social care, have all been amongst those experiencing a higher prevalence of long COVID. Not necessarily surprising when you consider they're more at risk of being exposed to COVID in the first place. But the second change is that in those aged 16 or over who are not working and are not looking for work, and now it's not possible at this stage to say whether the increase is being driven by new long COVID symptoms among those already out of work, or if it's people with long COVID moving into being out of work. I think it's safe to say that the trend could be an indication that long COVID is forcing people to take either early retirement or leaving the workplace altogether, and that absolutely prompts the need for there to be better support. We did a big survey of workers with long COVID last year, which I think you've probably already heard of some of in a previous hearing. We're currently doing a new survey to update our evidence base and the experiences of what it's like in work. But I will say we're hearing from unions that it is becoming more difficult to access support, as David's already said. And it seems like perhaps that sort of sympathy that might have existed during the pandemic, well, earlier in the pandemic, is kind of waning as employers are dealing with these long-term consequences of having more and more workers basically with long COVID. And there's also a real confusion amongst employers about what their duty is to people with long COVID and what they need to be doing to protect people going forward from being exposed and from developing these long-term illnesses.
Thank you. And in terms of a compensation scheme, what are you calling for?
Well, I'll just start by saying there's growing data demonstrating that exposure in the workplace is a significant source of COVID infection, which would prompt some kind of occupational relief. We've been saying consistently that isn't being taken seriously enough, including in the way that COVID is regulated and reported in terms of workplace exposure. Is that
by that do you mean Riddle?
Yeah, absolutely. We wrote a report on COVID and Riddle underreporting about a year ago. A serious concern that employers weren't being told to report instances, let alone them being followed up seriously enough.
What's the consequences of that Riddle reporting not happening? What does that mean?
Well, consequences are that regulators won't then go and investigate instances where there's particular outbreaks and large numbers of reporting in a particular workplace. And it also has a potential knock-on effect if there is going to be the introduction of COVID prescription, for example, and workers being eligible for industrial injuries disablement benefit, which we fully support. That will then be difficult for them to prove that there was a workplace exposure because the Riddle report wouldn't have been made. And it's difficult for them to then say that there's evidence that they were infected in the workplace and is therefore an occupational exposure. So it is really important, even going forward, that those reports are made. But ultimately, the employers are reminded that report needs to be made.
Thank you very much. That's very helpful. And if I can move to Leslie. So Leslie, your remit is very specific. Perhaps for the benefit of those who are less familiar with IAC, can you explain what does IAC do and what's IAC's involvement with long COVID?
Yes, thank you very much, because Shelley and David have raised some very important points. And you're absolutely right. What we do, the Industrial Injuries Advisory Council, we advise ministers in terms of diseases and occupational circumstances which might be eligible for industrial injuries disablement benefit. Now, IIDB is really almost unique in most countries among internationally, because it's a no-fault compensation scheme. So once the prescription has been accepted and it's changed the legislation, then for a person who claims, they do not have to prove for themselves the link between the occupation and the disease. So it's a very special compensation scheme. And I think it is our only standard compensation scheme. So we advise ministers on this. However, it's challenging because we have to be sure we've got robust evidence that there is within reasonable certainty that there is a link that the disease is caused by exposure at work. In other words, balance of probabilities, more likely than not. So we're quite demanding in terms of the evidence that we need. If I may, Leila, I'll just give a background to what we've been doing up to now, because we have some positive news and some negative news. So the council have been evaluating and monitoring the constantly changing literature and evidence since April 2020. And we produced an interim report in February 2021.
Yeah.
Which was basically based on data during 2020, which was mostly mortality data. And IIDB is not really set up for mortality, it's set up as for a disability. And but we did identify that from the death data in 2020, there were several sectors where excess mortality was significantly raised, such as the health and social care, but transport, food processing, security, local and national administration sectors, and so on. Since then, we've been monitoring a lot more data. We've had a lot more data on infections, sickness absence, outbreaks, as Shelley has mentioned. And we have now produced what we call as a command paper, where we have actually made recommendations to ministers in terms of prescribing for IIDB a range of very serious pathological complications following COVID, that we've got evidence that there's these can show persistent impairment and loss of function to some people. And I don't think I'm giving anything away, because if you read our minutes, which are open on the website, you'll know what these are. And I'll just go over them. And we are actually in the process, these are actually in the process of being looked at by ministers, the Secretary of State. And we hope that these will be accepted, but we don't know yet. And they will be laid before Parliament, and we can formally publish the report. But we are recommending for health and social care workers that people who have, I'll give you these some examples: persistent pneumonitis, fibrosis following acute COVID pneumonitis, persisting pulmonary hypertension following a pulmonary embolism, if you've had a stroke, if you've had myocardial infarction. And the one that I think is nearest to the sort of symptoms that David was highlighting is symptoms of post-intensive care syndrome, which is a well-known syndrome for people who've been in intensive care or critical care. I think we have to remember that a lot of people, there were so many people severely ill that they weren't always in ICU, but the critical care was outside ICU. Following ventilatory support for COVID-19, and these are our recommendations.
Okay. Since
then, we've been continuing to monitor, first of all, for other occupations. We have less but more, we're closely monitoring transport workers. We know that the proportion of deaths for taxi, cab, coach drivers due to COVID was far in excess over 2021. So we're particularly interested in them. We're interested in food processing. We are interested in outbreak data. We have very little at that. There's an early paper, but we know that there is work going on by the Health and Safety Executive in that. But we have challenges. We need robust data. And at the moment, we don't have a clear and widely accepted definition of long COVID, nor a diagnostic procedures. The populations are very variable in study design, in sample size. Some of them, a large number of them, don't have a proper comparison group. And it's the lack of validated measures which makes it very challenging to apply IIDB. But we are continuing to monitor that, and we'll almost certainly in some future time produce a third report and recommendation.
Thank you very much. Just very quickly before I move to Baroness Masham, we have been calling for more money, for example, to be put into research into long COVID. Would you like to see some of that money go towards decent data that you can then rely on? Is that something that would be helpful?
I will answer your very last question now then. One of our major problems is that occupation isn't routinely collected as a data. I'm sure it's a data item on databases, but for example, there are some fantastic population studies using hospital inpatient data, outpatient data, GP data. Occupation is not routinely collected or reported on. And so that's one major thing. If everybody collected or asked their patients, what do you do or what did you do if you were retired? Because many diseases, obviously not COVID, occur after retirement. And then the other thing is to do some proper occupational studies. We so far have not found a good, certainly not in the UK, study in terms of general occupational groups on long COVID. ONS data are fantastic, but they're limited, shall we say, in terms of occupation. So yes, we need more. Everybody says this, we need more data, but with occupation, it's not a topic which is, it's probably, I shouldn't say this, but it's not fashionable.
Well, that's our job, is to try and make it fashionable, but thank you very much. Baroness Masham.
Good morning. It's so good to hear what is being done, and there's more to come. How will you think employers are facilitated to manage how long-term sickness due to long-term COVID is in their workplace, and who would they go to for advice? Could we have BMA first?
Yes, of course. So in secondary care, there is a very established hierarchy. We have excellent occupational health physicians that are embedded within the secondary care forum, and that can then support individuals, and we work with them for the phased returns to work with the appropriate personalized activity management plan. A lot of what we've learned from ME, we are running for this. I think one important element when it comes to the secondary care forum is actually, and it comes a little bit back to what Leslie's just said, that whereas people who were hospitalized for COVID, there is a very clear, this is what happened. They were hospitalized, they went to ITU, they were quite severe. The vast majority of healthcare workers who are suffering with long COVID are non-hospitalized. And for those individuals, we do face all of those problems that Leslie said, that there is no diagnostic test. And within Stimulate ICP, the trial that I'm involved in, we are collecting data on occupation, we are collecting socioeconomic status, but there isn't a good diagnostic test, which does make it rather difficult. The bit where there are major failings is in primary care, because of the way that the primary care is established, with every GP practice, every big partnership becoming effectively an independent employer, they don't have the same access to occupational health support. They also have this rather almost a catastrophic position where they are effectively a small business, many of them with only 4 or 5 employees, some of them larger, but within that small business, they have to both try and support their existing staff and make sure the population that they serve are well looked after. And when they have a fixed budget in order to do that, and there is no occupational health, that does put the GPs particularly, but also the nurses within the secretarial support, who are very likely to have caught COVID when the doors were open, who don't necessarily have those same occupational health protections. So in summary, secondary care, we do have a great occupational health support. We still don't have the diagnostic tests, although we are working on it. And I would say, please don't hold your breath on that, because we've been looking for those in ME for the last 40 years, and we still haven't found a good diagnostic test there. But the primary care network just does not have the support that they need in order to both protect the doctors, many of whom who have subsequently lost their jobs or lost their partnerships, and also the other allied healthcare professionals working in that primary care system. And something is urgently required to support those people back into the jobs, particularly given the shortage that we've got of the whole primary care workforce.
Do you think primary and secondary care should be working closer together? Better communication?
The communication is there, and actually locally we are providing the occupational health support to those primary care doctors, but the financial support that goes with it is something that is very difficult, because the secondary care doesn't actually have the resources to be providing the additional funding for every GP practice, when effectively the secondary care is dependent on those GPs to be commissioning the work from it. So the professional support, the use of the long COVID services, the use of the occupational health and return to work, that's there, but it's also that financial personal support that is required as well.
So there is a problem.
There is a very, very big problem for long COVID in primary care.
Thank you so much. Now we can come to the TUC.
Yeah, thanks, Baroness. We're finding really that employers are failing in their support for people with long COVID. And that's either through a lack of willing, but more so, I think, through a lack of understanding of what long COVID is and what kind of support should be expected. There's just an example of what workers with long COVID have told us, that there is a lot of experiences of disbelief or not feeling able to talk to their employer about their symptoms. 25% hadn't told their employer, 20% told us their employer had questioned the impact of their symptoms, really doubting that, you know, it was real. Of those who did speak to their employer, a lot of them not getting the changes that they needed. So a third of respondents told us that they only got some of the changes they'd asked for. 8% got none of the changes they'd asked for at all. And the most frequently asked for change from workers is a phased return to work, so that they can kind of be accommodated and have a bit of flexibility. 63% had had some form of phased return implemented, but many have had problems with it, including kind of taking on too much work within that phased return and having then knock-on negative effects on their health. There are some other problems as well. So more than 1 in 6 told us the amount of sick leave they'd taken had triggered absence management and feeling like they have to go back to work or they'll be disciplined. A lot of them having to take unpaid leave as a result of having long COVID, being threatened with disciplinary action. 1 in 20 have been forced out of their jobs altogether because of long COVID. So in terms of what you asked about where people can go for support, I would obviously say workers should approach their union for support and for representation with those kind of issues. But we also need employers to focus on flexible working and understand what that means. We need regulators stepping in where there's instances of workers being put at real harm. We also need greater access to occupational health professionals in a real meaningful way, and generally a better understanding, more accommodating approach. If I may just quickly make a final comment, coming back to the classification of COVID as an occupational disease, following on from what Leslie was saying before, just to say we are out of step with other countries. The ITUC compiled a report, and more than 50 states, including the US, Australia, Canada, France, have schemes recognising COVID as occupational with corresponding compensation or benefit schemes. What we really need is relevant ministers to implement any and all of those recommendations from Leslie and her IAC colleagues made in that command paper that she mentioned.
That's very helpful. The trouble is so many people don't understand long COVID. Now we have Ilaf.
Thank you very much. Well, a couple of things really overlapping, I think, with question 6, which is about prevention. First of all, I wonder whether there might be it might be useful to make people more aware, for example, of the Health and Safety Executive websites, because they have extremely good information for a start, and guidance. They do expect employers to include COVID in a risk assessment. So how many risk assessments get carried out? Who knows? So that's one thing, that people are aware that for prevention of infection to start with, and not getting COVID is important. So we're stepping back a bit, but people seem to have forgotten that now. And so they have a very good facilities, which I think there should be more awareness of. Similarly, the Faculty of Occupational Medicine, and they have produced guidance for healthcare professionals return to work for patients with post-COVID syndrome, but also guidance for managers and employers on return to work for employees with post-COVID symptoms. And I think again, there's probably lack of awareness generally of what is available for occupational groups, and we have a faculty. So I would encourage more awareness of both what the Health and Safety Executive do and the faculty. The other thing I wanted to mention is the availability of risk reduction measures to workers. There's been it came out as a preprint, but it's recently been formally published on vaccination coverage by occupation, using our vaccination records. So that is a good population set of data which the ONS have analysed, and there's a marked difference between occupations in terms of the proportions of people who've had any vaccination whatsoever, and up to 3 now. And for example, for 3 vaccinations, it varies between 80 to 90% for health professionals, teaching professionals, to under 60% for construction, elementary trade operations, and so on. It's a huge disparity. And one has to bear in mind that for workers who can't get the time off, can't spare the time, who are working in uncertain hours, shift work, access to vaccination and other reduction measures is really important. And that data backs up how unequal this is. It's even unequal within the health service. So if you take medical professionals, 90% will have had all their vaccinations. If you take care assistants, it's much lower. So we have good data. So that's a big area which we could do something about.
How would you encourage people to have vaccination when they don't want to have it?
Well, that's a real challenge. But on the other hand, if you've got easy access and you've got people coming round to your workplace or mobile or all sorts of things like that, then if you see your fellow workers having their vaccinations, then that might help.
Thank you very much. Thank you, Baroness Masham. Thank you. If I can now move on to Baroness Brinton.
Yes, thank you very much. Layla asked earlier about long COVID being classified as an occupational disease, but can I ask if those living with long COVID can rely on the Equality Act 2010 to secure the support they need, specifically using long COVID symptoms as a disability in order for people to get that support? Can I start, please, with Leslie?
And this is not within my remit and my expertise. So I think I will miss that one out if that's all right, and go on to the people that do know about the Equality Act. Thank you.
I'm going to ask Shelley next.
Sure, I can say a little bit. So the Equality Act states that a person's disabled if they've got a physical or mental impairment which has a kind of substantially adverse and long-term effect on their ability to carry out normal day-to-day activities. We've already really heard about how long COVID meets that. Long-term means 12 months or more. We know many long COVID patients are experiencing symptoms for up to 2 years, let alone 1 year. And substantial means that it's more than minor or trivial. And it's important to remember that those as well with existing disabilities the impact of multiple impairments is really important for those with long COVID, and a lot of them that are experiencing symptoms for a long time have got underlying health conditions as well. At the moment, those with long COVID need to prove on a case-by-case basis that they meet that definition, and if they believe they've been discriminated against, they can make a tribunal claim. That helps us build case law around long COVID, but they take a long time to come through. They're expensive and time consuming, let alone for any worker, let alone a disabled worker. So we want to see the Equality Act strengthened so that everyone with long COVID is recognised as disabled. What does that kind of mean in practice? It could mean strengthening the statutory code of practice to include long COVID examples, or adding long COVID to the list of named disabilities, the language that's used by the Equality Act, automatically protected by the Equality Act, and that could be done through secondary legislation. But I think it is important, it is a real urgency actually for government to kind of give clarity around people's rights, both for workers and employers, and it would be a really clear and decisive action in order to protect those with long COVID.
Shelley, thank you. Just before I come to David, can I go back to Leslie, because I think Shelley's answer has helped me ask you a very targeted question, which is the reports that you've been talking about that IAC have been producing and some of the other ones you've referred to, do they help with a clearer definition of long COVID and how it might be disabling?
Not at the moment, I would say. We're actively working on this, but it's very difficult because there are real problems, real challenges in the data, because as David and Shelley have explained, there is a wide range of symptoms. Many of the studies are self-reported. They're just becoming, starting to come through more objective measures of some of the symptoms. But it's a real challenge if one is relying on self-report in terms of IIDB. I mean, if I asked 100 people, do you feel tired all the time? Have you got fatigue? A large proportion would say yes. And so these symptoms are very common in the general population. And what IAC have to do for IIDB is show that it is a really clear link. So we really need some very good occupational studies where occupation is clearly defined, that link these symptoms, and so that the symptoms are clearly, the data on that is clearly collected. So it's a real challenge, and we are actively looking for data, but there's very little in the UK that gives us that robust quality of data at the moment, and we hope we'll be getting that in the next few months.
Leslie, thank you very much indeed. And David, over to you. Could I just, after Leslie's answer, just add to your question, which is about whether there is enough evidence about chronic fatigue as opposed to just people feeling tired as a symptom?
So, I mean, the overall question, I have absolutely nothing to add to what Shelley said. She did a fabulous, basically pretty much exactly the same as I was going to say. We would also want long COVID to be specifically referenced in the Equality Act. When it comes to the diagnosis of this, as Leslie highlights, this is an incredibly complex area to attempt to diagnose. People who are hospitalized, it's relatively easy. We can see the hospital record and we know that there's a high prevalence of them that go on to develop long COVID. But actually, the vast majority of people with long COVID were not hospitalized. You know, although you're twice as likely to get long COVID if you were hospitalized, only 5% of the population with COVID were hospitalized. Therefore, the vast majority weren't. When it comes to diagnostic criteria, there is no blood test. It's a diagnosis of exclusion by definition. So we are very much dealing in symptoms. In chronic fatigue syndrome versus chronic fatigue, that has been a hugely controversial in its own area in its own right. Chronic fatigue syndrome is characterized by a post-exertional malaise. So I know many of us will feel fatigued. I have a 4-year-old daughter. I feel fatigued all the time, but I don't have chronic fatigue syndrome because I can account for that. What is what is going on in long COVID and ME is the fact that it's a massively disproportionate fatigue that goes with whatever it was. So, for example, if somebody was previously working for 8 hours a day and absolutely fine at the end of it, now get to 2 hours and need to sit down and rest, that's a disproportionate response. The problem is quantifying that. And to date, we don't have a robust way of doing that. There is plenty of research underway in the long COVID sphere and the ME sphere, and actually across the world, the UK is still leading the research in both of those fields, but it is still a very, very long way to go before we have a robust test that we can say, yes, just turn up, do this, and we will do, we can then say you have severe or moderate or whatever the term is. So we are dependent then on self-reported symptoms, and that's where you then start developing issues with legal cases, with case-by-case evaluations, and an understanding of a disease that we don't have a test for yet.
Thank you very much indeed. Back to you, Leila.
Thank you very much, Sal. If I can now come to Caroline Lucas, and just to say, with apologies, we are going to run ever so slightly late. I hope that's not a problem for any of the panelists. Please indicate if so, but I think it's really important to hear fully from you. So with permission, if we can keep you just a bit longer, and thank you in advance to the second panel. We are coming to you. I hope you agree it's important to hear all the answers. Caroline Lucas.
Thanks very much, Leila. Yes, I wanted to come back to the issue of the employers, and maybe a question for Shelley in the first case, which is, are there existing guidelines for employers to give them more information about how to deal with long COVID among their workforce, and what could be done to improve the state of guidelines?
Yeah, thanks, Caroline. Well, the answer is not enough. Leslie said it earlier, we've taken massive steps back on prevention controls. Some of the things that we think need to be put in place, particularly a requirement on action on ventilation. Airborne protection is the most effective means of protecting the largest number of people from COVID aerosol transmission. We need to have a much bigger effort to get employers understanding and acting on that. We'd also like to see grants to allow public services and businesses to upgrade their ventilation systems when necessary. But a really simple thing employers can immediately be doing is acquiring CO2 monitors, using those to measure the fresh air supply in indoor workplaces so they know when to start taking action. But there's lots of things that have been undone that we'd like to see reintroduced. For example, COVID testing should be made free again. You know, if you're low paid, you can't afford to get tested anymore. You also can't afford to take time off to self-isolate because sick pay is a poverty payment. That needs uplifting to meet the cost of living demands, and also to remove that lower earning limit on it, which means lots of low paid workers aren't entitled to it at all. I think that's a really important, preventative control measure. Bringing back face masks on public transport and in shops, and introducing a proper standard on face masks is something that we've been saying since that requirement was removed. We also need employers to still be including COVID in their risk assessment, as Leslie said earlier. There is a legal.
I might just stop you there, because I think you're almost answering the next question. The question that I was asking was question 5 around guidelines for employers about how they deal with employees who already have long COVID.
Yeah,
so
who already have. Okay.
Yeah, it says that's not how to prevent them getting it, but if they've got it, are there guidelines out there that tell employers how they should be treating their employees who have it?
Yeah, well, I talked a little bit about this earlier in terms of the flexibility that needs to be made available to
but are there guidelines? What I'm trying to get at is
there's little in the way of guidelines, essentially.
So who should, do you think, be coming up with some guidelines, so that you can think of small businesses perhaps in particular who might just simply not be in the circle of knowing what the best practice is in terms of dealing with employees with long COVID?
We need formal government guidance, just like we did with infection control measures. We need government guidance that mandates employers to support people. We need that followed up by strong regulation from the HSE and others. There's some really good guidance from the Society of Occupational Medicine, and there is stuff out there, but it's not mandatory. Employers don't have to do it, so we need formal government guidance.
Okay, that's really helpful. Thank you. And sorry to interrupt you in your full flow, because what you said was very important. Leslie, do you have anything to add on that?
Well, I thought you brought up a very important point about small and medium-sized enterprises. I think large employers probably are fully aware. They will have health and safety managers. Some of them have occupational health services for their workers. But with all of occupational health, the problem is access for small and medium size, and particularly the self-employed as well. We mustn't forget self-employed. And as Shelley says, and I said it a little earlier, the Society of Occupational Medicine, the Faculty of Occupation do have good guidelines, both for the managers of employers and the employees themselves. But I suspect that many of the people in many of these industries, first of all, have never heard of, well, they might know health and safety, but they never access any of these good online materials. And so the main challenge I see of this is, as Shelley said, I absolutely agree with her, getting this information out. And perhaps the way to do it is to have blanket coverage by media and so on, and good links, so that people are aware of these available information, because it's out there.
Lovely, thank you. And David, I'm not sure if you wanted to add anything.
No, I mean, it is very much about this small and medium-sized businesses that need support. As Leslie said, the large industry has their occupational health, and it's the support that's going to be required both for the individual with the condition and also the managers. You know, if you've got a staff of 4 or 5 people, and all of a sudden you have to support somebody who caught COVID in the line of duty, they have to be supported. If we get long COVID mentioned specifically in the Equalities Act, then they would give the legal protection for those people. But those managers, those small businesses will need the additional support as well. Otherwise, we're going to see the small businesses going under just as they're trying to do the right thing by their staff.
Thanks very much. That's a really important point. Thank you all. Back to you, Leila.
Thank you very much. Over to you, Lord Strasburger.
Good morning to you all. We all know that prevention is better than cure, and in particular, I want to ask what more we could be doing to prevent people who suffer from COVID to graduate onto long COVID. Is there more that we should be doing? This is probably an answer for a question for the BMA, so I'll ask David to go first.
Well, actually, Shelley's already covered a lot of what I'd like to say. COVID itself has disappeared from the news. We've got new variants have arisen. There's hospitalizations have shot up. We are seeing new cases coming into hospital here locally. The prevalence in the community is going up, and nobody is talking about it. We've got the specifically, I mean, we've got the XBB, BF7, and people just don't want to hear anymore. The vaccine uptake for the bivalent boosters isn't going the way it should be doing. We are seeing really good data that bivalent boosters are protecting people against both acute COVID and hospitalization, and all the indicators from previous work suggest that that's also going to reduce the risk of long COVID. We saw in the previous waves that good vaccination reduced the risk of long COVID by 42% in the ONS data, and that's been mirrored around the world. Yet the same push isn't there. Mask wearing, really simple way of reducing your transmission risk, because we're not testing. We should have free testing, particularly for those in lower income jobs and for those people who have got a high risk of transmitting. Remember that the best way to prevent long COVID is not get COVID in the first place. And then for those people on the low income jobs, particularly at a time of a cost of living crisis, we need to make sure that if they do test positive, they are supported to stay home until they are testing negative. We changed the guidelines around the BA1 variant, and we did see that at the time it was probably the right thing to do, that it had a very short transmission phase. The latest data on the new variants say that you will or you are infectious for a lot longer, and many people either A, don't know they've got it, or B, even if they do, they're told they can return to work as soon as they're feeling okay. And just because they're feeling okay doesn't mean the next person that they pass it on to is going to be feeling okay. In Singapore, they did the studies where they had this test to return to work, and they provided the support for people to stay at home. If you're on a low income, you're in a low income, we don't need to go down the cost of living crisis. But if you've got a choice of either risking spreading COVID to people or putting food on the table for your family, you know which way it's going to go. And that's the additional support that's going to be needed. So it's a simple vaccination program. Start talking about it, hospitalizations, etc. Try and get people wearing the masks again in the social spaces, the carbon dioxide sensors that Shelley's already mentioned, supporting schools and workplaces to get better filters, better aeration, and keep all of those things underway and keep it on the spectrum, because it won't be long before the next pandemic arises. The changes that we make now will protect us both from long COVID today and the future.
You're quite sensibly saying that the best way to stop people getting long COVID is to stop them getting COVID. But is there anything we know about what we can do to prevent people who do have COVID not getting long COVID?
The trials are all very much in the early phase. There's been several anecdotal reports talking about earlier antiviral therapy, earlier and administering vaccines, administering antibodies. All of those are anecdotal at the moment. Actually, we have just got we've just got the funding to do the first study to be administering these antivirals to prevent long COVID occurring. The problem with all of this research is it takes time. And it will be, to be honest, it's going to be too late for the millions of people who will track it before we actually have the data on the best way of preventing it. So what we're really looking at is what's the best way of preventing this for the next pandemic rather than the current pandemic.
So you seem to be saying we don't know how to do it with COVID.
We don't yet know. We're looking at treatment for it, not good prevention. The only way to stop getting it is be fully vaccinated and don't get it in the first place.
Understood. Is there anything the other two panelists want to contribute to that? If not, I'll move on.
Just quickly, in terms of anecdotal findings, I was of the understanding that reinfection looks like it perhaps increases the risk of long COVID, and the more times you're exposed and get it. So it just kind of emphasizes the point of prevention from getting it in the first place is the most important thing. And just a further comment on vaccines as well. Employers can really help by giving people free time off to attend their vaccine and booster appointments rather than making them go outside of working hours. That's, I think, a good way of encouraging people to actually get vaccinated.
And sorry, just on that vaccine point, we also need to be reaching communities that we are not very good at reaching. And they're not hard to reach. It's just that we are not set up to reach them. We need to be going to the temples, the mosques, the people from those different backgrounds with different challenges and get them in workplaces or in that environment that we can get to them. There is no hard to reach population. It's just we are not reaching them in the right way.
Okay, Chair, back to you.
Thank you very much. And to round us off, if I can now go to Barbara Keeley.
Thanks. Well, we've had some incredibly rich responses there. So for each of you, Shelley, Leslie and David, what is your key recommendation to the UK government? We'll start with you, David.
We need to start talking about COVID again. We need to be implementing these protections, and they're not restrictions. A face mask is not a restriction. It is a protection. It reduces your risk of spreading COVID to people around you. So you're protecting the people that you care for and people you don't yet know. If we're talking about it, we need to be then looking at the best way of protecting the population from COVID. And then the research programs that are already underway, and I'm quite fortunate or quite honoured to be part of some of the biggest NIHR funded studies into this. But the NIHR studies, in fact, all of the studies in long COVID and looking for treatments of it are back to the original bureaucracy that went with research in the pre-COVID era. During the acute COVID, we saw that this country can respond quicker than anywhere else in the world when it comes to establishing and producing high quality research that demonstrates to save lives. When it came to long COVID, all of the red tape, all of the administrative barriers have been put back in place, which means people are suffering for this for years without being given the path that they need to the potential, maybe not life-saving, but disease-altering and quality of life improving treatments that we potentially can be looking for.
Thank you. Shelley, can I come to you?
Yeah, sure. Two really quick ones to finish off. Coming back to prevention, we want to see tougher enforcement action and more proactive inspections in sectors where the number of COVID outbreaks remain high. The Health and Safety Executive in particular needs to act quickly and apply sanctions to employers, but it has suffered enormous cuts over the last decade, more than 50% of its funding cut. If we're going to be pandemic prepared going forward, we need a well-funded, functioning safety regulator. And then secondly, implement the IAC recommendations, recognise COVID as an occupational disease, and give those who were exposed at work with long-term illness access to the financial support, whether that's in the form of IIDB or compensation or something else.
Thank you, Shelley. And Leslie, last word to you.
Thank you very much. Well, I support all the recommendations so far. I will reiterate that will please researchers and population data collectors, please take occupational as an absolutely mandatory data field, because we can't recommend to alter the legislation unless we have the data. We just can't, because it's all written in the legislation. And the other plea I would make is for, and this has been mentioned before, but to think about the people who, as David says, have little access to prevention methods, either because of the nature of their work, because of their interactions with their family and domestic circumstances, and make prevention available more equally to people. Because as we've said, obviously not getting it is the best thing, but there are large numbers of people who have forgotten about COVID, but don't have easy access to the preventive measures which they really should have.
Okay, thank you. Back to you, Chair.
Thank you. Well, all that's left for me to say is a huge thank you to David and Shelley and Leslie. Thank you so much for giving us extra time. It's very much appreciated. You are very welcome to stay and listen to the next panel if you so wish, but you're also very busy people, and if you want to just go, we completely understand that as well. So thank you again for your time, and I'll now move to the second panel. So if the second panelists would mind turning on their videos, then we'll do that. Well, so we've just heard from experts who are looking at this, in some cases in very data-driven clinical ways, but none of this can really make sense without talking to people who are themselves affected by long COVID. And we fully appreciate how difficult it is and how physically exhausting it can be to be part of these panels. So I'd like to thank you all very much for being here at all. Just to reiterate, if at any point you feel too tired, can't carry on, or just, want some breathing space, that's absolutely fine. Just let us know. We are all fully briefed and understand that may be the case. So please don't feel any pressure whatsoever. So what I'll do is simply ask you to introduce yourselves at this point, and perhaps if you could also say, what did you do? When did you get COVID? And with specific focus on your employment, what's your situation now? Perhaps I could start with Michaela Martin. Michaela, I'm sorry, we can't hear you. I'm not sure what's happening there. It doesn't look like you're on mute, which is the normal issue. So I wonder if your speakers are in. Michaela, perhaps why don't I start with someone else? So maybe Sarah, if I could start with Sarah, and then you can have a fiddle with your computer. Sarah.
Hello, pleased to meet everyone. I'm Dr. Sarah Mason-Whitfield. I'm a senior doctor who's been working over 20 years, predominantly in emergency medicine and general practice. Forgive me if I stumble a bit, because I've got quite marked cognitive difficulties, which, other than the fatigue, which I will come to, is probably the most prominent feature of long COVID, which has a very marked impact on people's employability and the safety of them working as well. I worked at the front end, ran the front end of an emergency department from February 2020 in London, assessing all patients who arrived other than those that were going direct to the resus room. So everyone else who came in ambulances, walked in, cars, arresting in front of me in the waiting room, all came via me for a risk assessment, diagnostics to try and get anyone who could get home, and everyone else stratified into the appropriate area. We had blue surgical masks at that point. We were not allowed to wear FFP3s unless we were doing an aerosol generating procedure, which was, intubation. And this is an aerosol driven, level 3 biohazard. Surgical masks are utterly insufficient, and that is the situation ongoing. I was fine for a year and a half. I think in retrospect, I probably had COVID in December 2019 with hindsight, but recovered fully. Unfortunately, on the 4th of March 2021, I had my second Pfizer vaccination, and it transpired that I had an asymptomatic COVID infection at that time. So I had 2 hits of spike protein at the same time. And within a day, I was developing neurological consequences and cardiac problems. For me, mine was a very rapid transition because of the vaccine as well as the COVID at the same time. But let's be clear, we are not all just fatigued. And I am embarrassed to admit I had no concept of what fatigue with ME meant prior to me experiencing this. It is like the battery in all your cells has run out of charge. It is not being tired. I've got a child. I've worked having had 0 sleep overnight, and I can manage. Already sitting here for an hour, I know I am going to be wiped out for the next week. It is not go in and do 2 hours at work and then you feel a bit tired. Sorry, I'm losing track now. So I have neurological and cardiac problems. I have less fatigue than other people. I'm not bedbound. I probably would not fit into the ME category. My greatest problem with regarding work is my cognitive problems. And whilst I can now speak freely and speak much faster than I could, I previously sounded a bit like a zombie. It is very dire. It has improved a bit because I happen to be on a medication to help my blood pressure, which has been wrecked as a consequence of neurological damage, and it allowed greater perfusion to my brain. So my processing speed has improved and the speed of my speech has improved. However, I cannot add 8 + 4. I don't know what change I should get in a shop. Sometimes I don't recognize the value of the money I'm handling. I have essentially no working memory. If someone tells me something that I need to remember, by the time I have picked up a pencil that is in front of me, that has exited my brain and it will not be remembered because I haven't stored it in my memory yet. I can't follow a 2-part instruction. I can't follow a recipe. I get lost following a sat nav that's telling me where to go. I can't use public transport safely because I get lost, even on journeys I have done for 20 years. I can't plan. I can't problem solve. I can't hold more than one thought in my head at a time. And as a doctor, when you're just doing basic consulting, you're having 4 conversations at the same time. You're talking to the patient. You are working at a differential diagnosis. You're trying to work out what it could be, what it isn't. You're assessing what they look like, their body language, and in A&E, listening out for the person who's about to break into your room and assault somebody, So if I can't speak to someone whilst the kettle is boiling, how can I function as a doctor? I certainly can't hold a scalpel because of muscle reasons, but my judgment, everything is gone. There are lots of healthcare workers who are working who don't classify themselves as having long COVID, but have these cognitive problems too. There are airline pilots. There are gas engineers doing this. I fought for a year. Pretty much the doctors with long COVID, and there's a group of about 2,000 of us, have been more successful in getting assessed and treatment. We're also liaising with lots of researchers around the world, outwith of the UK, because a lot of that research is actually further forward. But despite me being persistent and a bit stroppy, it took me a year to get a formal neurocognitive assessment, which is now confirmed. What my worry is that I am unsafe for medical practice. That is a permanent situation. Neurocognitive research is not restorative. And so I have now lost my career after 20+ years. the majority of the doctors group are in the same situation. Because of the way I was employed through the hospital, I was clinical lead in the emergency department as a GP. We were employed through the hospital bank, which is temporary staffing, if you like, although I'd been in the same position for 3 years and done exactly the same shifts and was on the rota, was involved in managerial meetings, mortality meetings, the lot. Because I was employed through the bank, my trust have decided not to follow the NHS England guidance that said all bank workers should be paid for isolation and becoming unwell with COVID. I did get isolation pay, but I had to fight for it. I got statutory sick pay for 28 weeks, and I've had no pay since then. And this is the case with any doctor or healthcare worker in primary care, anyone in the community, so that includes all hospice workers, because they're charitable foundations, they're not NHS, any locums, anyone who is staffing community hot hubs. So about 50% of healthcare workers have not had special COVID leave. Mm-hmm. I'm on universal credit. All my savings and anything else has gone because I had to pay bills. My 98-year-old grandmother has prevented me losing my house so that I have a home for me and my 9-year-old daughter. I have, luckily, as a doctor, we have some medical benevolent funds, which a group of doctors are now working with, because we're looking at how can we fundraise more money to support us, the hundreds of colleagues that are joining since Omicron started, the numbers joining healthcare worker groups, doctor groups, general long COVID support groups have shot through the roof, and they are increasing day by day. I have the benevolent funds helping me. They can't do that longer term because the people that they supported before long COVID was a thing have increased as well. Other people have health issues. We have doctors who are very bad mental health issues. The domestic violence has increased. So the demand on all the benevolent funds, which are not just limited to doctors, there are teaching benevolent funds, there's lots of them. They are under massive pressure as well. I am now having to consider selling my house, moving back into my mum's house up in Edinburgh, and using the equity in my property to be able to pay for myself going forward. And I know I'm going on a bit. The point of that is all the public workers, and I know a lot of teachers who are in a similar situation, we're being refused for ill health retirement because there seems to be a blanket ban on long COVID or post-COVID syndrome. And post-COVID is a multi-system thrombotic problem that causes cardiac and neurological damage in it predominantly, but also multi-organ failures. And they're refusing ill health retirement on the basis that we don't know the timeline of long COVID and it might all just spontaneously recover itself. Well, 20 months later, I still can't add 8 and 4 together, so I'm never going to be able to be a doctor. If you have been refused ill health retirement for a public pension, you have no right to come back and apply for that at a later time. So that's then completely shut off. We've got no compensation. 50% of us are all in financial destitution anyway because we didn't get special COVID sick leave. So the only prospect I have of surviving going forward is universal credit. I'm lucky enough to have obtained PIP, which is not easy to get at all, plus the equity that I have in my house. And I'm exceedingly grateful that I have a property that has equity. The reality for most people is that is not the case. I'm really grateful that I have evidence of a really shocking cognitive deficit. I've gone from high superior in most domains. I'm now down in low average or impaired, which is learning disability level. I feel lucky that I have that because that means I might be able to get ill health retirement. But none of that. I also have autonomic function tests that prove that my sympathetic nervous system just isn't working at all. I'm lucky to have that because I was able to access it. The majority of people cannot get access to any of that healthcare or assessments whatsoever. Mm-hmm. Sorry, I'm getting a bit angry now. As a doctors group, and some people were on this journey over a year before I was, have been shouting for all that time, study the doctors. We can explain in medical language what is going on with us and identify all the smaller symptoms that lots of people won't even know about, and use us to help everyone else with long COVID. Every appointment I go into, If they want to do any random test that they want, bring it on, because if that gives them information that can help the hundreds of thousands of people in the community that can't even get into a long COVID clinic being run by a physio or an OT, you know, you're never going to have a situation again where you have so many medical staff who have an idea of what's going on and can explain very clearly what's going on. You're never going to have this situation again with a new disease with so many medical people who have it all at the one time. But our experience and our knowledge is being utterly disregarded and not being utilised, which is why we're liaising with researchers in lots of countries around the world, but not really the UK, because nobody wants to speak to us.
Thank you very much. And
sorry, that was a long answer.
No, that's fine. You've covered some of the questions later on as well.
Yeah.
On the finance stuff. So perhaps if Maddie and Michaela, when you answer, we'll come back to you perhaps with the finance stuff. But just as a bit of background, you know, what were you doing? When did you get it? How has it affected you now? Maddie.
Hello everyone, and thank you for everything so far. I was working as a train driver, driving freight trains around the country when I caught COVID in May 2020. I think I must have caught it at work for the simple reason I was only going to work and nothing else at that time. I was well looked after by my employer, thankfully, which was good. My symptoms are very similar to Sarah's, but also I'm very mobility impaired as well and have to spend most of my time in bed, as I am at the moment. It's pretty severe. My initial illness was mild. I just stayed at home for 11 days and I had the pulse oximeter to see if my breathing was okay. And then I recovered and thought about going back to work. But 2 days later, after recovering, the long COVID hit. It was just like a switch was flipped inside me, and all the fatigue, pain, dizziness, everything just hit at once. And nearly 2.5 years later, I'm no better. In fact, I'm probably a bit worse. I lost my job, which I absolutely loved and have been doing for 22 years. Because there's no way I can do any job, even just an easy office job, because my cognitive function is shot. Since then I've also managed to get PIP, even though that was quite a distressing experience getting it. I'm also in the support group for ESA, Employment Support Allowance. So I can just about survive on those two. Thankfully, our mortgage is paid off, so that's less of a worry. And my husband's working. So
could I ask about the support that your employer gave you and what the situation is with them now? Have they sort of allowed you retire? How's it worked with you not being able to work now? Are they still supporting you?
Not now, no. They did wait almost 2 years to see if I would recover. So I started off being paid fully, and then I went to half pay, then SSP.
Mm-hmm.
And when the SSP ran out, I went on to ESA. And then in March this year, they decided, you know, I'm not getting any better. There's no other job I can do. So they let me go.
Understood.
I was gutted.
Yeah.
But I realised that they had no choice.
Understood. Thank you very much, Maddie. And if I can ask Michaela the same question. So Michaela Martin, when did you get it? What did you do? And what's your situation now?
Thank you, Layla. I contracted COVID in December 2020. I've had to write notes, so I apologise if I don't look like I'm looking at you. I get in a muddle as well. So I was working as a maths teaching assistant in a high school. And I wore a mask because I've got many members of my family that were extremely vulnerable. But at the time, the pupils didn't have to wear masks in class. The classes were really full, so it was impossible to space pupils out. And even though we had doors and windows open, we were with, 30 plus pupils every lesson in one room, and it just was impossible to do anything else to change that. I worked with a pupil who later that day, his parents phoned the school and said that his PCR test had come back positive, and his sister was already off school with COVID at the time. We didn't know that. And that's just, you know, that's one of those risks that being in an education setting. I know school was the source of my infection because we had so many vulnerable people in my family. None of us were mixing. And I didn't go out anywhere to do anything other than go to work. And when I had my PCR test done, I also got my husband and my daughter who lives with us to do one as well. They were both negative. So I know I was the source of, you know, where that came from. Since then, so that was back in December 20, I tried to get back to normal, even though I wasn't very seriously ill with COVID in January, and January 2020, and I just couldn't do it. My body, it's a very strange fatigue to explain, but it's as if energy just drains from the tip of your head right down to the toes, and it can happen as you're trying to climb stairs, or you wake up just feeling ill every day, aches and pains all over my body. Strangely, the soles of my feet and my heels, which I just don't understand. But like the previous two people have said, you know, it's the brain as well. It's not just physical aches and pains. I struggle to retain facts, to retrieve words, particular words they'll get stuck on in sentences. I'll be going into a room to do something which I've thought of 2 minutes before, and then within 2 minutes I've lost it. I can't think, and I know that happens to a lot, but this is happening every day, all the time. It's I can't describe it other than to say I've lost myself. I don't know who I am anymore. I've lost my health. It's affected my confidence. My career, which I was in for 25 plus years, I can no longer do my job. I need to be able to switch topics in my head quite quickly to help pupils remember the methods, explain the methods, and show and model things. I can't even do that for the simplest of things. So I can't be of help to them anymore. I haven't been able to go back to work at all. And it's not just my work that suffered, it's my home life as well. I can no longer do the things that I love doing. So we'd go for long walks, my husband and I would have long walks together. Can't go on dog walks. I can't do the gardening I loved. Even things like a family trip to our favourite beach. Where I live, beautiful beaches that go for miles, but there's dunes that you cross to get over them. So they go without me and I stay at home with the dog. And it's just, I know it probably sounds like a very small thing, but putting it all together, it's affected the quality of my life, and who I am as a wife and a mum. This has taken me away. Yeah, it's more than tiredness. It's a complete change of my personality as well, and who I am.
Thank you, Michaela. That's so difficult and difficult to share. So probably to swallow. Thank you very much.
Thank you.
Can I ask specifically about the school and their reaction to it and their understanding of long COVID and the way they approached it? Could you expand a bit on that?
Yes, I count myself as extremely fortunate, actually. I have a head teacher who has been so empathetic and understanding, and she was, from the word dot, wanting to help but not knowing how. And the head of HR as well. I have had several what they call well-being meetings with them both. And they have waited all this time to see if I could get better. And it was at the last meeting that we had before the summer holidays that I think we all came to the same conclusion, and that is we can't find a solution in how to get me back to work. And so they've been discussing, or they put out there the idea of early medical retirement. Nothing's been done about that yet. I've been waiting all this time to see someone from Occupational Health, but I know they are inundated, so I haven't actually seen them yet. Work were very good in that they did report my case under RIDAL. I asked about that sort of earlier on in the hope that if anything came about for compensation with the government, then at least my case was on paper somewhere, and they didn't hesitate to agree to that. So they couldn't do anything about financially supporting me any longer than is the norm. So my head really wanted my sick pay to be extended, but the trust policy was such that that wasn't going to happen. So I am no longer paid, and that's just the way of things. Yeah. Other than that, I mean, they also there's a well-being policy with work where we can have counselling if it's helpful. So I was able to have a couple of sessions of that, and I think that's another element of this illness that is really important to be heard about, is your mental health in being this ill and not knowing when it's going to end, if it ends at all, is affected hugely. It knocks your self-esteem, and yeah, you have really low days, and it's nice to be able to see other people and hear other people's evidence as well, because you suddenly think, I'm not alone.
Well, Michaela, you certainly aren't, and thank you so much for sharing all of this today. I appreciate how difficult it is for all of you. If I may now go to Baroness Brinton for the next question.
Yes, thank you very much. You've all three of you, to some extent, answered the main bit of the question, which is about finance. But I think at least two of you said you had managed to secure PIP. And I wondered how hard it was to get it, and was there a recognition of long COVID, or was it entirely done on what you can actually do at the moment? In other words, long COVID was almost incidental. Michaela, I want to start with you, because I'm not sure if you have managed to get PIP.
I applied for PIP and I was declined. And as others have said, it's probably almost one of the most demeaning things you can do, is to try and persuade someone to believe you when you say you're ill and you need help. And the forms are formidable. There are pages and pages of trying to justify why you need help. And to go through that and then be told, well, we don't believe you, really, that was hard. I hit a real low at that point. I wasn't aware at that time that I could have claimed for ESA, and that was something I did more recently. I have claimed ESA, and I was told that I did fit that criteria. But I've seen, and you have to go through a very long process too with that. So it's phone appointment to go through everything, filling in forms, sending medical evidence, which I did, and they lost it all. So now I've been told that I now need to be reassessed because I didn't send the medical evidence. So I haven't had any of those payments. So I'm going through it again. So next week I have to start again with that, which, when you struggle anyway, mentally and verbally, and I mean, I'm got little notes here to make sure I make sense and go in the right order. It's so draining. It's so draining, and it doesn't do your self-esteem much good.
Indeed. Thank you. Maddie, could I come to you next, please?
Yeah, I'm claiming PIP at the moment. Like Michaela said, that form is horrendous. It took me about a month filling it in a little bit at a time. I got turned down originally, but I was lucky enough to have an advocate from a ME charity who said I should go for a mandatory reconsideration. And I got it then, thank goodness. I'm now going through a change of circumstance review because I've got worse. So I'm just waiting to hear how that's going. Very, very stressful. The ESA, I had the same actually, they lost my form as well. But thankfully I had typed it and I had it in the memory, so I just reprinted it and restuck it down and sent it back off again. Both of them are very degrading to apply for. The ESA was a bit easier. I didn't need an assessment for that. They just realised that I was okay to receive it just by reading my form, basically. So.
Thank you very much. And Sarah?
Hi, yeah, so I got PIP on my first go. However, I obviously have a very distinct advantage here. And also when I worked in general practice, I also had patients who had lost their PIP, so when they got moved from disability living allowance. So I was well aware of the situation with PIP. It took me 3 weeks. I didn't write it on long COVID. I wrote it on every single symptom and diagnoses that I have, which are part of my post-COVID syndrome. I don't particularly like the term long COVID because it is viewed as, oh, bless, feeling a bit tired, are you? It's a multi-system organ damage disease. I basically wrote a dissertation for every symptom. I feel very sorry for the person that had to read it. But there is an excellent UK ME benefits group on Facebook, which has loads of information on it. And essentially what you need to do is have the criteria for the points for that each section, write what you have that fits to that, why it cannot be any less than that, and then close off any loopholes they will find to argue that you don't deserve it, such as, well, you could use this aid. So you need to write, I don't use this aid because I can't hold it, for example, or it will, a stick would then become a trip hazard. But, you know, I'm medically trained. I'm a massive advantage to be able to do that. And the vast majority of people will not be able to do that. In our doctors group of the people applying for PIP, I would say maybe 10% got it on first go. The statistics for PIP, 30% will get it on mandatory reconsideration, which remains with the company that assessed you in the first place. If you then go to tribunal where there are actual doctors there, you get 70% are then awarded. That's an enormous waste of money by the Department of Work and Pensions. I mean, it's just preposterous. What is not talked about is the number of people that are self-harming and killing themselves in the process of waiting for that. I have to say, having been through the benefit system now, the amount of wasted time and energy and money that happens in various offices around the country as part of DWP is just insane. If it was a private company, it would have folded years ago. I'm astonished by it. Carers allowance, we have not applied for carers allowance, because for universal credit, they removed that pound for pound from the universal credit amount. Unlike if you have earnings, in which case you can earn up to £500, I think, a month before you start being removed money. And then it's less than half, 50p per pound is then removed. With carers allowance, it's removed pound for pound immediately from universal credit. And the person that is being cared for will then lose their council tax reduction. So we haven't applied because we would be worse off with carers allowance. Again, the mind boggles. Can I make a small point about RIDOR, which you may not be aware of? One of my colleagues used the Freedom of Information Act to gain all from every trust in England and Wales, they didn't manage it for Scotland and Northern Ireland, about the RIDOR reporting. And I believe there were 4 RIDOR reports by NHS trusts in the entire country. Everything else got shut down. None of us can get RIDOR reported. The response from the people in our workplaces is, well, we don't know you didn't get it in the garage. Or, we don't know that you didn't get it from a staff member at work. How do we know you got it from a patient? The RIDOR reporting cannot be used in any way because none of the hospitals are doing it, and the primary care trusts just don't have the facility to do that. That is a major problem.
Thank you. Very helpful, very depressing.
Thank you.
Back to you, Leila.
Thank you very much. If I can go to Barbara Keeley, please.
Well, thank you all, and I'm so sorry to hear of all this struggling with DWP. I guess those of us that work with this as members of Parliament and other parliamentarians are not surprised by it, but it's still horrific to hear what that system's putting you through. So I'm sorry about that. Well, my question maybe links to that. What support do you hope to see put in place for yourself and others living with long COVID? It might be a completely revolutionised and different system from DWP, or it might be something else. Could I start with you, Maddie?
If it could be considered an industrial disease and we'd be given an allowance from that would be fantastic.
Okay.
That would be the best thing, really.
Thank you. And Michaela?
Yes, I think that would make our lives a lot easier. We wouldn't have to try and convince so many people. I feel there's a lot of times when we're in situations where we're being offered help, but then you find yourself trying to prove that you need that help. It would be very nice if it was recognised as an occupational disease, and also for people to actually believe it's a real thing. I've had one horrible experience with an NHS member of staff that was a consultant who saw fit to tell me that it didn't exist and why he didn't think it existed. And that really knocked me for six. I was then very reluctant to go and ask for help elsewhere for quite a while. And I think it is, unfortunately, a misunderstanding of what this illness can do. And it would be lovely to see it recognised as a genuine illness. So we're not spending all our time trying to make people believe us. Yes, the financial support would be amazing if that could be possible.
Okay, thank you. And Sarah, to you.
Sorry, what was the question again?
What support do you hope to see in place for yourself and others living with long COVID? So, might be what you've just talked about, or might be something else.
Financially, specifically for NHS workers, equity between those in substantive secondary care posts and those who are not, because that's thousands of pounds different in income so far. Obviously, that has now been closed. Acknowledgement that certain occupations, particularly health and social care, education, and public transport workers, this was more than likely contracted at work, and that should be recognised and dealt with. Multiple European countries and other countries around the world have already put compensation in place over a year ago. We're way behind this, particularly for their healthcare workers. And also for public pensions. I don't know about private pensions, but for public pensions, to have ill health retirement closed down as an option, and I know multiple teachers that this has happened to as well. The doctors group, the nurses and midwives group, and the teaching group are all in close connection with each other because we're all suffering similar issues with public resources. To have ill health retirement shut down as well means you're just subjecting thousands and thousands of your public workers to financial destitution, essentially. What else would I want on a non-financial basis is for people to start wearing proper masks, FFP2 masks, to stop people getting COVID. The amount of people that are joining long COVID groups right now is huge. COVID, the rate of COVID right now is astronomical, but nobody talks about it. We need to stop people getting COVID so that they hopefully don't get long COVID. Vaccination helps a little bit, but it helps with the severe complications and it helps with psychosis. The evidence from Oxford recently suggests that it doesn't actually help terribly much with the neurological problems and the cognitive issues. Expanding the reason to stop people getting COVID, lots of people who don't identify as having long COVID have cognitive issues. We're going to end up with a real brain drain problem in this country and around the world. if we don't address this and the cognitive issues. As it is, how do you run a country if you don't have enough people in healthcare and you don't have enough education staff? Those are big places that are getting worse and worse and worse. The NHS is in absolute tatters right now, but there are more and more people getting long COVID. Sorry, I've lost completely where I'm going now. But people need to know. They need to know the risks that they are risking their neurological system, their brain, their livelihood, and their risk of death in the upcoming months. And the public don't know it. The media won't talk about it. COVID is over. It's utter nonsense, complete nonsense. It's a level 3 biohazard. Anthrax is a level 3 biohazard. We wouldn't be wandering around without masks on if there was anthrax around. Sorry, gone off in a rant again.
No, don't worry. This is the safe space for you to rant. That's why we're here.
Absolutely infuriated by it. And between 10 p.m. last night and this morning, I had 70 text messages and emails from various different doctors and nurses and pharmacists with things they wanted me to say.
Sarah, thank you for your answers. Thank you. And thanks, Maddie and Michaela too.
Thank you. Lord Strasburger.
Good afternoon to you all, and thank you very much for sharing what you're sharing. You've touched on this, I think, already, but I'm just going to ask you a quick question, some very simple question, to which I hope you can give quite a short answer, actually. How do you think your situation would be improved if long COVID was recognised as a disability? Sarah, do you want to go first, please?
The short answer is I would be financially better off and substantially less stressed about mine and my daughter's future.
Thank you. That's very simple. Maddie, would you like to go next, please?
The same as well. It would be much easier to claim for benefits if it was a recognised disability.
Right, and Michaela?
Yes, if it was recognised, I wouldn't feel I have to keep justifying myself. So
Yeah.
mentally, it would really help me.
Yeah, all that form filling and all that
Yeah.
bad treatment that you've been through. Thank you very much. Back to you, Leila.
Thank you very, very much. And for the last question, Baroness Masham.
Thank you so much for all what you've given us. It's really been useful. And my last question is, what is your key ask recommendations to the government? And it's very important you tell us so we can tell them. First of all, we'll have Sarah.
Thank you. I think mine is threefold. You need to be protecting the population from getting long COVID, but my vested interest would be to protect the NHS and teaching staff, because you're going to wreck the country otherwise. That would be the first thing. People need to wear masks and we need HEPA filters. Second of all would be helping those that are currently suffering, both financially and trying to prevent financial destitution, but also to help them access care. And that is woefully lacking at the moment, regardless of the long COVID clinics, because most of them are run by physios and occupational therapists. And very dire medical things are being missed, and people are turning to doctor patients on the internet to try and see what help they need to get. We as a group are supporting hordes of people unofficially to get them the care that they need. And third of all, I know that David spoke about the NIHR and research. Some of the funding that has been used for research in the UK has gone to some of the most dubious research you can imagine, such as does talking therapy improve long COVID symptoms, such as does Slim Fast weight loss powders improve long COVID symptoms. We need proper biomedical research happening that is happening around the world and is not happening in the UK, and the UK are ignoring the research that is happening in various other countries because it didn't happen in the UK. Unless you sort out all three issues, we are going to continue on the track of lots of people ending up with long COVID, which is neurological and cognitive damage and other organs. The financial situation of the country is dire because, well, it's dire anyway, but I'm not going to get into that. But this is a large number of working aged people. You are then also choosing to wreck your education system and your NHS because of the number of people in those areas that are being affected. So if you want to stop the country just deteriorating further, we need to halt the progression of people getting long COVID.
Thank you so much. And now we have Michaela, please.
Thank you. I think the one thing that I would like to say first is please don't forget us. We were being clapped on doorsteps at one point and thanked for being out there as key workers. And now I feel like we're forgotten. I feel we were told as education members of staff that schools were safe places to be. I can remember that phrase very well. And this was at a time when schools and colleges were actually transmitting COVID quite quickly between them and sending it back to their families. And I just feel now is the time where, please, can we ask for help in return now? We did our bit, which I didn't hesitate to do. I saw that as my role, and that's what I did. But now we need the help, we need the support, and I feel that we are forgotten. And if you could declare COVID an occupational disease, that would make our lives very much better.
We will not forget you. This is why we have our group, and this is why we try to promote this to the government and to the world. Also, could we have Maddie?
Yeah, the same as Michaela and Sarah have said so far. I agree with them. Also, can we have much better long COVID clinics? A lot of them is just a nurse with a telephone or a nurse running a clinic. Can we have a proper one with doctors so you can be looked at all over and make sure nothing's being missed? That's my biggest wish. Also, more financial support. If it could be an occupational disease and we could get money from that, that would be so helpful. And also making the DWP make it easier to get benefits. It feels like they think we're liars and have to prove that we're ill. Can they just make the process a little bit gentler somehow? That's all.
Thank you so much. You really have been wonderful, the three of you. I hope you keep well as you can. Thank you.
Thank you, Baroness Masham. And this ends our session.
Layla?
Yes, Sarah.
Sorry, could I just say something to Maddie and Michaela? I really want to apologise to you two on behalf of some of my medical colleagues, because as senior clinicians, we are being laughed at by some of our colleagues in clinic. But, you know, we're quite stroppy doctors and we can get through that. But as a group of clinicians, we are despairing at what is happening to non-medical patients. And Michaela, that should never have happened to you. It's happened to me from a neurologist. I wasn't able to retort back to him because I sounded like a zombie and I couldn't speak. He thought I was anxious. And you both deserve an awful lot better than that. And I despair of what is happening within the medical profession as well, who are just utterly overwhelmed. And even the ones that I would expect to be behaving in a better fashion are completely unable to do so right now. So it's easier to just push people away. Maddie is absolutely correct about the long COVID clinics. These should be medically run clinics that have then access to all hospital specialist clinics, whereas in reality, even if you do have a GP or doctor run clinic, they try to refer to specialists and are then refused. So the gaslighting is not just happening to the patients, it is also happening to the GPs. I have GP colleagues who phone me for advice on how and who to refer to and who's working privately that can possibly see their patient because they are being refused all referrals. This should not be happening. It's great that we have lots of long COVID clinics, but they are not doing what they say on the tin.
No, they're not fit for purpose.
I just wanted you two both to know that all the medical people with long COVID really, really know what you guys are going through and the treatment that you're receiving as well. And we're doing everything we can to educate our colleagues so that they don't behave like that.
Oh, well, thank you, Sarah.
Thank you so much.
No worries.
But I will say it's not for you to have to apologise. And I think the importance of this group is that we will be taking everything you've said, including what we're hearing about the reality of what it's like to be living with long COVID in the current system, right back to the doorstep of ministers. We do appreciate that there is a lot of turmoil in Westminster, but actually this group is trying to be a beating heart on this issue. And to Michaela's point, and to reiterate what Sue said earlier, we will not forget you. We absolutely will not forget you. Thank you so much, all three of you, for giving evidence. And I'm sure there are many at home who will watch what you've said with a sense of enormous relief, because they also realize that they're not alone and that there are others who are going through what they're going through. So thank you so much. You've given us a lot to take on board and a lot to take forward. And we very much appreciate the toll that this in turn takes on you. So please continue as best you can to look after yourselves. Thank you so much for your time. Thank you so much to the parliamentarians, the Secretariat, and everyone watching at home. And so concludes our session today. Thank you very much. Take care, everybody.
Thank you.